thyroid carcinomas are a heterogeneous group of tumor that shows considerable variability in their biologic behavior, histological appearances, and response to treatment therapy. Although benign thyroid nodules are common, they are clinically detectable thyroid carcinoma is very rare, representing about 1 to 1.5% of all malignancies and 0.5% of all cancer deaths. The incidence is 25 to 40% cases per million population per year. Mostly thyroid carcinomas occur in adults and they are rare in children. Increased frequency is there with increasing age. Papillary carcinoma may be found in childhood. Now, this is the classification of the different types of the thyroid carcinomas. Basically, the thyroid carcinomas are classified as the primary thyroid carcinomas and secondary, because secondary means due to the metastasis. Daniel further classified as differentiated and undifferentiated. He classified that what is a primary carcinoma and what is a secondary carcinoma. Primary malignancies of the thyroid can be classified according to element, according to the epithelium, according to the tissue from which they arise. Secondary carcinomas are the secondary tumors, occur extremely rare, but these are blood-borne metastases, usually occur from primary carcinoma, the breast, colon, kidney, and melanomas. Means these are not the primary arising from the thyroid tissues, but these are the malignancies of the breast, colon, kidney, or the melanomas, which spread to the thyroid, means metastasis occur to the thyroid. These are the secondary tumors. Others are the metastatic lesions. Third one is the local infiltration. And types of primary carcinoma. Now, I've told you that carcinoma is classified into primary and secondary. So, what are the types of primary carcinomas? As per the tissues of the thyroid, the epithelium of the thyroid from which they arises. And number one, tumors of the thyroid follicular epithelium. Tumors of the thyroid follicular epithelium. Okay, these are the papillary carcinomas. Papillary carcinomas could occur about 60% cases, follicular carcinoma 17% cases, Hurthle cell carcinoma 3% cases, Anaplastic carcinoma 13% cases. Now the papillary carcinoma, the follicular carcinoma, and Hurthle cell carcinoma, these are the differentiated, and they are occurring in 90 to 95% of the cases. Anaplastic carcinomas, these are undifferentiated, and these undifferentiated thyroid carcinomas are found in 5 to 10% cases. Tumors of parafollicular cells, these are the pellicular cells. These are the type which is arising from the parafollicular cells is the medullary carcinoma. It is found in 6% of cases. Tumors of the lymphoid element, this is lymphoma. Now, etiology. What is the etiological factors, predisposing factors which are causing the thyroid malignancies? Number one is the ionizing radiation, endemic goiter, lymphocytic infiltration, oncogenes, papillary thyroid carcinoma, oncogene. The oncogenes for papillary thyroid carcinoma, these are divided into the oncogenes 1, oncogenes PTC2, and the PTC3. Now the clinical features. Clinical features of the thyroid carcinomas, how the thyroid carcinoma patient is presenting. The commonest presenting symptoms is the thyroid swelling. Initially, the patient comes to us with a presentation of a thyroid swelling. The patient will present with a swelling in front of the neck, and that would be a thyroid swelling. The thyroid swelling, what could be the characteristics of that thyroid swelling? Thyroid swellings are firm, irregular, or fixed. Enlarged cervical lymph node may be presentation of the papillary carcinoma. Locally advanced disease may present with hoarseness of voice due to recurrent laryngeal nerve paralysis. Now, in advanced stages, what happens? The thyroid carcinoma causes there is the spread of the disease, and there is the spread of the disease causing the paralysis of the recurrent laryngeal nerve. So that may result into the hoarseness of voice. The patient of thyroid carcinoma may present with the dyspnea or dysphagia. The dyspnea, because these symptoms are because of the pressure effects. The tumor presses the trachea, causing the dyspnea, and the tumor presses the esophagus, causing the dysphagia. And pain, often referred to the ear, occurs in infiltrating growth. So these are the clinical features which are patient may present to us with a thyroid carcinoma. Anaplastic tumor, if it is a tumor of anaplastic origin, it will present with the patients with anaplastic tumor present with painful enlargement of thyroid, which is often fixed, moving poorly on deglutition. The anaplastic carcinoma tumor is very much aggressive, and it is present with a fixed tumor, and there is fixed tumor and very hard tumor that moves on deglutition. Patients with medullary thyroid carcinoma usually present with a single nodule of multiple nodules. And involvement of lymph nodes occurs in 50 to 60% of cases. Hoarseness of voice and dysphagia may be present. Diarrhea is a common feature in 30% of cases. Patient may present with signs and symptoms of distant metastasis like weight loss, anemia, body aches, and pains. And now we are going to discuss in detail the very common and important type of the thyroid carcinoma, that is the papillary carcinoma. Papillary carcinoma is most common type of the thyroid carcinoma in all of the other types. It is occurring of 50 to 80% of cases. It occurs in all age groups. It's a slow-growing tumor, more malignant with the advanced age. If it occurs in advanced age, it is more malignant. Usually it is present as an asymptomatic nodule in the thyroid gland and or as an enlarged cervical lymph node. Initially, the patient comes to you, there would be asymptomatic nodule in the thyroid gland. There is a single nodule in the thyroid gland, but it is asymptomatic. No symptoms are there. And sometimes it may present as the enlarged cervical lymph node. It is spread via the lymphatics both within the gland and outside the gland. Blood-borne spread is a very late feature, means the metastasis of papillary carcinoma through the blood-borne occurs in the later stage. Diagnosis, regarding the diagnosis, we can go for the other investigations like the thyroid function test, the thyroid function test, ultrasound thyroid, but these are not diagnostic. From diagnostic point of view, fine needle aspiration biopsy is very important. We get a FNAC, fine needle aspiration biopsy, that will confirm us about the type of a malignancy. Then if it is malignant, then we can go for the CT or MRI of the neck to see any metastasis or local spread. Okay. Now, what is the treatment of papillary thyroid carcinoma? It's the surgery. If it is a single nodule occurring in the one lobe of the thyroid, then lobectomy with isthmusectomy is a sufficient treatment. But if we have a suspicious of other nodule and the other lobe, then near total thyroidectomy or total thyroidectomy are the two options. And for the lymph node dissection, we have go for the modified neck dissection. And after the surgery, we keep the patient on the thyroid hormone suppression therapy. And then we have to go for the post-operative radioactive iodine therapy and sometimes the external radiations. Okay, now other type, that is the follicular carcinoma. Follicular carcinomas are second most common form of thyroid cancer. Follicular carcinoma after the papillary carcinomas are the second most common form of thyroid cancer. About 10 to 20% of all thyroid malignancies are the follicular carcinomas. It is a higher incidence in iodine deficient areas as a result of chronic thyroid stimulating hormone stimulation. It occurs in older age group, usually in the 40 to 50 years of age. According to Mayo Clinic series, follicular carcinoma occurs at a mean age of 55 years. It occurs more often in women because the thyroid enlargement or thyroid goiter is more common in women as compared to male. Lymph node involvement is much less common than in papillary carcinoma. It spreads through the lungs, bones, brain, and via bloodstream. This is the distant metastasis. And like the diagnosis of the papillary carcinoma, here the diagnosis is confirmed by the FNAC is not reliable because FNAC will not differentiate between the vascular and capsular involvement of the follicular carcinoma. And the differentiation between the follicular adenoma, means the benign condition, and the follicular carcinoma, the malignancy, the differentiation between the follicular benign tumor and the malignant tumor, means from the benign adenoma to the follicular carcinoma, is on the basis of vascular and capsular invariant. So FNAC will not tell us the difference between either the capsular or vascular invariant is there. So it is not a diagnostic. So diagnosis is confirmed by the histopathology. Means if we find out there is a nodule in one lobe, so we do a lobectomy and send that lobe for the histopathology to the laboratory. That will confirm us that it is malignancy or not. Regarding the other routine investigations like the thyroid function test, we can advise ultrasound neck, we can advise IDL, we can do, and later on, after confirmation of the diagnosis by the histopathology, we may advise for the CT scan and MRI to confirm the local and distant metastasis. CT chest or X-ray chest is also important to detect out any metastatic lesion in the chest. The treatment of the follicular carcinoma, again, if the one lobe is involved, we can go for a lobectomy with the somerectomy, but for a curative purpose, we have to go for the total thyroidectomy is better the option than the lobectomy alone. The therapeutic net dissection is done to remove the lymph nodes, and other is the thyroid hormone suppression therapy, and then after the surgery, post-operative radioactive iodine therapy is advised. Oh, now the third type, the medullary carcinoma. Medullary thyroid carcinoma was defined as clinically entity in 1959. It was discovered by the Hazard and Associates. And medullary carcinoma is a neuroendocrine neoplasm derived from the parafollicular or C cells of the thyroid. It occurs in about 5 to 10% of thyroid malignancies, and it occurs in sporadic hereditary clinical settings. It arises sporadically in about 80% of cases, while 20% are inherited on autosomal dominant basis, means these are the familial cases. Familial cases may occur as a part of MEN2, the MEN2 multiple endocrine neoplasm, 2, when there is the association in MEN2 multiple endocrine neoplasms. It's a syndrome in which there is the pheochromocytoma and hyperparathyroidism in association with the medullary thyroid carcinoma. Means the medullary thyroid carcinoma, pheochromocytoma, and hyperparathyroidism occurs in that single patient, and we label it as the MEN multiple endocrine neoplasia type 2. So familial cases may occur as a part of MEN2, means in association with the pheochromocytoma, hyperparathyroidism. Medullary carcinoma occurs in association with pheochromocytoma and hyperparathyroidism, so we label it as a familial type of medullary carcinoma. Usually present with a neck mass associated with a palpable cervical lymphadenopathy in 15 to 20% cases. Local pain is more common. Diarrhea is a feature in 30% of cases. It spreads to local lymph nodes and superior mediastinum, that is about 50 to 60% patients. Distant blood-borne metastasis are also common and occurs to liver, bone, and the lung. Local invasion into trachea and oesophagus also occurs. Again, the diagnosis is established by history, physical examination, raised serum calcitonin level, because the hyperparathyroidism may occur in association with the familial type of medullary thyroid carcinoma. FNAC of the thyroid mass is give us the diagnostic suspicious about the medullary thyroid carcinoma. Attention to family history is important, and should we ruled out by marrying the 24, there is coexisting pheochromocytoma, because pheochromocytoma may occur in association with the medullary thyroid carcinoma. In familiar type of medullary carcinoma, because these both are included in the MEN2. So we have to rule out the pheochromocytoma by measuring the 24 hours urinary levels of vinyl mandelic acid, VMA, uh, and serum calcium levels are also raised in cases of familial medullary thyroid carcinoma because of the association of hyperparathyroidism with it. CT scan, medullary carcinoma spreads frequently to the cervical lymph nodes. CT scan may help to indicate metastatic cervical lymph node involvement. And regarding the treatment of the medullary thyroid carcinoma, this is the total thyroidectomy, central neck node dissection. If superior mediastinal lymph nodes are found involved during surgery, they also should be removed. Tumor debulking, in case of very large tumor, metastatic fixed tumor, and prophylactic total thyroidectomy is also done before the occurrence of the medullary thyroid carcinoma in those patients who have the history of the medullary carcinoma or who are the known cases of MEN2. So we will go for the prophylactic total thyroidectomy. Means before the prophylaxis means before the occurrence of the disease. Adrenalectomy is removed because of the pheochromocytoma, and parathyroidectomy is also done because of the involvement of the parathyroid glands, and other is the radiotherapy and the chemotherapy. And now the last type is the anaplastic carcinoma. Anaplastic carcinomas are the more aggressive and very advanced tumors, and these are undifferentiated tumors of the thyroid follicular epithelium. As I told you, the thyroid carcinoma is divided into the differentiated and undifferentiated thyroid carcinomas. So the differentiated thyroid carcinomas were the papillary, follicular, and medullary thyroid carcinoma, while the undifferentiated thyroid carcinoma is the anaplastic thyroid carcinoma. So these are the undifferentiated tumors of the thyroid follicular epithelium, and these are more aggressive, more advanced, and diseases. Unlike differentiated thyroid carcinomas, anaplastic carcinomas are highly aggressive tumors with a mortality rate of 100%. As I've told you, the anaplastic carcinoma is an undifferentiated tumor that is a very advanced aggressive tumor, and that is mortality rate is about 100%. These tumors account for 13% of all thyroid malignancies. They occur in old age group with a peak incidence in the 60 to 70 years of age, mainly in elderly women. More occurs in the advanced age. And now this is the anaplastic tumors present as a rapidly enlarging bulky neck mass. Means the patient will come to you with rapidly enlarged thyroid with a large mass in the neck, and on examination the neck mass or the tumor would be hard, it would be painful, it may be fixed to the surrounding structures and moves very poorly on deglutition because it is fixed to the trachea and surrounding structures. It is stony hard because it's a very aggressive tumors of undifferentiated epithelium. So the compression symptoms are too much in these cases, like the dyspnea, the dysphagia, hoarseness of voice, cough and stridor are common and occur at an early stage because it's an aggressive, advanced tumor. Its tumor is hard in consistency, it is very painful, and it is fixed to the surrounding structures. So because of its local spread in vein, it causes the compression of the trachea, resulting into dyspnea, and compression of the esophagus, resulting into dysphagia, and pressure effects on the recurrent narration are leading to the hoarseness of voice, cough, stridor are common even at the early stage of this malignancy. Lymph nodes are usually palpable, and most of the time these lymph nodes are hard in consistency. They are also fixed, and distant metastasis to the lungs is common in cases of papillary thyroid carcinomas. The diagnosis is confirmed by FNAC or true cut biopsy. Actually, the FNAC most of the time is not easily performed in cases of these hard and fixed tumors. So better is the true cut biopsy. The true cut biopsy will give us a good amount of the tissue that will give us a very clear clue regarding this type of the tumor. So FNAC is diagnosis for FNAC. Most probably the TrueCut is more beneficial, and we can go for the other investigations as well, like the thyroid function test, the CT scan of the neck and the chest, or MRI of the neck and chest. Indirect laryngoscopy is very important to see the status of the vocal cords, either disease has affected the vocal cords or not. So these are other, but the diagnosis is confirmed by the histopathology. And what are the treatment options of this anaplastic carcinoma? The surgery is a limited role. Total thyroidectomy, if the tumor is operable, it is resectable, and it is not too much fixed to the trachea and other surrounding structures, the total thyroidectomy should be done. But if the tumor is fixed one, not mobile, and it is not an easily resectable tumor, so we will go for the debulking thyroidectomy, means the isthmusectomy. We can only remove the isthmus to decrease the tracheal compression, means for the tracheal decompression, because the isthmus is lying over the trachea. So because of this hard and fixed tumor, it will cause the compression of the trachea, and a patient may develop the dyspnea. So it's better we do the isthmusectomy, we remove the isthmus, and this is called debulking surgery. And pressure is released from the trachea by the removal of the isthmus. The patient can taking the respiration smoothly, and other options are radiotherapy and the chemotherapy. So this is all about today's lecture regarding the thyroid carcinoma.